Artificial Intelligence Dr. www.abcpharma.net/English. User question: how does the body position or movement of the patient affect the spatial relationship between a leadless pacemaker and vagal nerve fibers, potentially leading to intermittent or position-dependent vagal stimulation? Claude AI answer: this is an insightful question that addresses the dynamic nature of the relationship between implanted devices and surrounding anatomical structures. The body position and movement of a patient with a leadless pacemaker can indeed potentially affect its interaction with vagal nerve fibers. Let's explore this in detail. 1. Anatomical considerations. Leadless pacemakers like the Avir VR are typically implanted in the right ventricle, often near the apex or septum. The vagus nerve branches extensively in the heart, with fibers running along the great vessels and into the cardiac plexus. 2. Effects of body position. A. Supine position. This is often the neutral position used during implantation. In this position, the heart sits more posteriorly in the chest. B. Left lateral position. The heart shifts slightly towards the left chest wall. This could potentially bring the pacemaker closer to vagal fibers on the left side. C. Right lateral position. The heart may shift slightly towards the right. This could affect the relationship with right-sided vagal branches. D. Prone position. The heart is pushed more anteriorly against the sternum. This could compress structures and alter the pacemaker's position relative to nerve fibers. E. Upright standing position. The heart descends slightly in the chest cavity. This vertical shift could change the spatial relationships. 3. Effects of movement. A. Breathing. Deep inspiration and expiration cause the heart to move within the chest cavity. This cyclical movement could lead to periodic changes in the pacemaker nerve relationship. B. Exercise. Increased heart rate and contractility during exercise alter cardiac dynamics. The more vigorous movement of the heart could lead to intermittent interactions. C. Coughing or Valsalva maneuver. These actions cause sudden changes in intrathoracic pressure. They could momentarily alter the position of the heart and pacemaker. 4. Potential mechanisms of intermittent stimulation. A. Direct contact. In certain positions, the pacemaker might come into closer proximity or direct contact with vagal fibers. B. Changes in electrical field. Alterations in the surrounding tissue, due to position changes, could affect how the pacemaker's electrical field interacts with nearby structures. C. Pressure effects. In some positions, the pacemaker might exert pressure on surrounding tissues, indirectly affecting vagal fibers. 5. Factors influencing variability. Individual anatomy. Exact placement of the pacemaker. Size and shape of the pacemaker. Degree of fibrosis or tissue encapsulation around the device. 6. Clinical implications. Patients might report position-dependent symptoms, e.g., dizziness, nausea, or changes in heart rate when lying on one side. Intermittent vagal stimulation could lead to inconsistent pacing or sensing issues. 7. Research and monitoring approaches. Positional ECG monitoring. Advanced imaging, e.g., dynamic MRI, to visualize device movement in MRI-compatible devices. Patient symptom diaries correlated with activity and position. Understanding these dynamics could be crucial for optimizing leadless pacemaker design and placement strategies to minimize unintended interactions with the vagus nerve. Would you like me to elaborate on any specific aspect of this position-dependent interaction or discuss potential strategies to mitigate such effects?